Let's move on to blood loss, specifically hemolytic, and that in this category, acquired. The red blood cells you're making are fine. MCV is normal. MCH is normal. MCHC is normal. What's the problem? Well, the red blood cells are spontaneously lysing. Why? Maybe you got bit by a rattlesnake. A lot of toxins from snakes and insects are hemolytic, which means they cause red blood cells to rupture. Maybe there are some drugs that the patient is adversely reacting to. That could cause hemolysis. Blood transfusions, where the blood types were improperly matched, can also cause hemolysis. So we would have the recipient's antibodies attacking the donor's antigens on the red blood cells. That's what you're seeing in the top right picture. As the antibodies attach to the antigens of the red blood cells, this will start the complement system, and the red blood cells would lyse. This is the same phenomenon that we see in hemolytic disease of the newborn, where the most clinically relevant type of hemolytic disease of the newborn is Rh incompatibility, where the mom is Rh negative and the baby is Rh positive. In this case, mom's antibodies against the Rh factor could cross the placenta and enter the fetus. Now, mom's antibodies attack the fetal antigens and cause rupture of the fetal red blood cells. When someone has blood loss, either because of hemolytic acquired or blood loss because of acute hemorrhage, obviously we can help that patient with blood transfusions until their own bone marrow replenishes the lost red blood cells. I just want you to be aware of that when we give transfusion therapy, we want to make sure that we don't have any blood typing mismatching, because if that happens, we can cause even more blood loss through hemolysis. So after we give a transfusion, we're hoping that we didn't give a mismatch of the ABO blood types. If we do, we're going to see signs and symptoms very, very quickly. We're going to see sensations of heat along the vein where the blood is being infused, flushing of the face. They might feel chills or fever, tachycardia, an increased heart rate, dyspnea, that's air hunger. I'll be telling you more about that as the semester goes on. But there can be other less severe blood transfusion reactions, some that are less sensitive. When we give transfusions, we want to collect the urine from the patient to make sure that we are not seeing any products from hemolysis that is arriving in the urine. By that, I mean hemoglobin is released from the hemolyzed red blood cells and filtered by the glomeruli in the kidneys. Two possible complications of a blood transfusion reaction are oliguria, which means no urine production, and renal shutdown because of the adverse effects to the filtered hemoglobin on renal tubular flow. The urine needs to be examined for the presence of hemoglobin, urobilinogen, and red blood cells because as the filtration membrane becomes damaged, whole red blood cells can actually seep through it. So these delayed hemolytic reactions are of concern. They may be even 10 days after the transfusion and are caused by undetected antibodies in the recipient's serum. Of course, we're most oftentimes worried about ABO blood typing compatibility, but there are other antigens on red blood cells that can also cause transfusion reactions. Moving on to the blood loss hemolytic category, but the inherited type. Thalassemia anemia is a good example. Now, the alpha globin chains that are found on chromosome 16, they're shown here as green boxes on the right hand of the screen. There are 2 genes on each chromosome, 4 genes total. The beta globin genes are found on chromosome 11. There is 1 copy of the beta globin gene on each chromosome. Let's first talk about alpha thalassemia. With alpha thalassemia, we need to think about how many of these 4 genes would need to have a mutation that would lead to no alpha gene synthesis. Now stop and think. If only 1 alpha gene was mutated and rendered the gene inactive, you have 3 others as a backup. This is redundancy. So a person who is a silent carrier of a single alpha globin gene mutation, they're going to be asymptomatic. That's what we mean by silent carriers. Even if they have 2 genes of the alpha globin genes mutated, the person will have alpha thalassemia trait, and they will exhibit very, very mild hemolytic anemia. However, if we get 3 of the genes mutated of the 4, what happens is we're going to have unstable aggregates. Your textbook says aggregates of alpha chains, but really what that means is the beta globin chains are going to accumulate. There's nothing wrong with the beta globin chains. We're going to get wrong concoctions of hemoglobin. We might get 3 subunits of beta globin chains to 1 subunit of alpha globin chain. These abnormal aggregates are called hemoglobin H, or HbH. They actually precipitate out of solution. The beta chains, like your textbook says, are more soluble than the alpha chains. So accumulation is going to be less toxic to red blood cells than the accumulation of the alpha globin chains that we're going to see in beta thalassemia. The most severe form of alpha thalassemia is going to occur when all 4 of the alpha globin genes are deleted or mutated. This is going to lead to Bart's hemoglobin, or HB-Bart. Now stop and think. Alpha globin peptides, we need them in embryonic hemoglobin. We need them in fetal hemoglobin. And we need alpha globin polypeptides in adult hemoglobin. So an embryo with a mutation in all 4 genes is going to have irregular aggregates. During embryogenesis, it will only be epsilon units that can come together. In the fetal period, it will only be the gamma units that can come together. Basically, most of the embryos are going to die in utero very early on in the pregnancy. If they even survive to birth, they usually die shortly after. If we're going to catch them, the survivors are obviously going to need transfusions for the rest of their life, and typically they're going to have other congenital defects because of the abnormal red blood cell hemoglobin synthesis. All right, so what you hear with that? We have 2 ways to have thalassemia. Thalassemia means we're going to have mutations in the alpha or the beta genes. If it's a mutation in the alpha gene, we say it's alpha thalassemia. We don't really see any clinical distress until the patient has 3 or more of their alpha genes mutated. The others are very mild. So only 1 alpha gene mutated, silent carrier. 2 of them affected, very mild anemia. Beta thalassemia, in contrast, is now when you have a mutation in 1 or both of the beta globin genes. Now this means that the alpha globin genes are going to accumulate aberrantly. The alpha aggregates are much, much more toxic, and they precipitate out much more rapidly than the beta globin aggregates that we saw in the alpha thalassemia. So the alpha chains denature because they group together aberrantly. They form precipitants, and these are called Heinz bodies. These Heinz bodies accumulate in the red blood cell precursors. They're going to impair DNA synthesis and cause damage to the red cell membrane, which is, of course, going to lead to hemolysis. These cells are hypochromic, microcytic, and their MCHC will also be decreased. Again, MCH down, MCV down, and MCHC down. That's going to be organ failure because of all the red blood cell lysis. There's going to be increased workload on the liver and spleen. Also, because the very, very pronounced hemolysis, we can have some of the components of red blood cells gumming up in the nephron and can lead to renal failure. Splenomegaly and hepatomegaly can result because the increased workload on the liver and spleen to remove those damaged and aberrantly sized red blood cells. Okay, again, with thalassemias, obviously they can get a blood transfusion, but particularly when we're talking about beta thalassemia or thalassemia major, also known as Cooley's anemia, this is a person who has both of their beta globin genes mutated. The red blood cells only accumulate alpha globin aggregates. These are not very water soluble. They precipitate out of the solution. The red blood cell is damaged from them. Therefore, they are removed very early from circulation. Because of the kidneys detecting reduced oxygen content in the blood, there's an increase in EPO that's released. This stimulates the medullary cavity to expand so that there's more room for the stem cells. They commandeer that area. That means there could be skeletal abnormalities. These people are actually prone to fractures because their compact bone is so thin. It's not very thick because the medullary cavities expanded so much. Because of the intense hemolysis, there's increased iron absorption and retention by the body, and this leads to iron overload and the hemosiderin that we've already talked about. Fetal hemoglobin can persist, and in fact, hydroxyurea is a drug that we can actually give these people that will cause them to revert back to their fetal hemoglobin. Now, we recognize that fetal hemoglobin has a higher affinity than adult hemoglobin. Therefore, less oxygen would be dropped off at the tissues for any given change in oxygen partial pressure. But this is better than nothing. This is better than having severe hemolysis. So either fetal hemoglobin can persist, or we can actually give them some hydroxyurea to convert the proerythroblasts to make fetal hemoglobin. Let's move on to hereditary spherocytosis. This is under the blood loss hemolytic inherited/intrinsic pathway. With hereditary spherocytosis, this is the most common inherited blood cell membrane disorder. Actually, I believe there is a picture that you can look at in your textbook. If you look at the black proteins there, the black protein is spectrin. Now, what happens with hereditary spherocytosis is it's a problem with maintaining the spectrin protein. What happens is there's a gradual loss of cell membrane. This is an autosomal dominant mutation, which means only one bad gene is enough to cause a problem. So the cells enter the circulation normally, but with time, they lose their cell membranes, so the cells will shrink. This will ultimately create microcytic cells, or reduced MCV. Essentially, the hemoglobin that they have is normal. They had a normal MCH, but as the MCV shrinks, we're going to have increased concentration of hemoglobin within that cell. So if you were thinking to yourself, sitting in a classroom, and you think of you and your fellow students as hemoglobin, and the walls of the classroom as a cell membrane, well, if the walls started to move in on you, wouldn't you all be moving your desks closer and closer? Wouldn't you all become more concentrated? That's a perfect analogy for the changes seen in hereditary spherocytosis. You, the number of students, means, or think about the amount of hemoglobin. That does not change. You are not being lost, but the volume you are found in is decreasing. Therefore, the concentration goes up. We can treat hereditary spherocytosis with a splenectomy. Basically, we are removing one of the two sites, the other being the liver, where red blood cells are removed from circulation. These red blood cells can carry oxygen just fine. The anemia is resulting from their aberrant size. They're round and they're small, so they can't maneuver through the reticular fibers as easily. Therefore, they are removed at a greater rate than being produced. Now I'd like to talk about sickle cell anemia. Sickle cell anemia is also under the hemolytic inherited column. This is a genetic defect in the beta globin chain, a different genetic defect than what we saw for beta thalassemia. In this case, it's in the 6th amino acid position, where normally the beta globin chain is supposed to code for glutamate, but instead of an adenine, a thymidine substitution leads to a codon that codes for valine. Now, glutamate is a polar amino acid, and valine is nonpolar. So we're totally changing the chemistry of hemoglobin. What exactly causes the sickling? Is it the mutation directly? No, it is actually the reduced oxygen content in the surrounding tissues that causes the sickling. So when there's low oxygen conditions, the beta chains link together and form these stiff rods. Red blood cells become sickle-shaped. They're going to clog blood vessels, and this is going to impede further blood flow. The surrounding tissue becomes progressively hypoxic and anoxic and leads to even more sickling. This is what's called a crisis. It's very painful, and the patient needs a blood transfusion right away. In patients that have sickle cell anemia, where they have two beta globin chains that have been mutated in this fashion, we say they have sickle cell disease. Even when they fall asleep, they can have crisis. Why is that? When they fall asleep, they have fewer respirations. We all do. There's actually less oxygen content in your blood as you fall asleep. When that happens, they have a sickling event. Now the type of hemoglobin that contains the sickled mutation is called HBS. That stands for sickle cell hemoglobin. These red blood cells are normochromic. The amount of hemoglobin, although aberrantly made, is still normal quantity. The cells, when they are not sickled, are normocytic or normal size and shape. But when they are going through an episode or crisis, they are poikilocytic. That means they are going to have abnormal shapes. When they're in these abnormal shapes, they are easily ruptured. That means hemolysis is occurring. Here is a picture of chromosome 11. We have a copy of the beta globin gene. We have two copies total, one on each chromosome number 11. These genes are codominantly expressed. That means we don't use one or the other. We actually have gene expression of both. So let's say a person has one chromosome number 11 with HBS allele, which means the mutation, the valine is being substituted. I should say the glutamate is being substituted with valine. Well, if that's the case, if you look down here on the second dash, then the genotype for that person would be HBB, and that represents the healthy allele on chromosome number 11. And HBS, that would represent the sickle allele on the other chromosome 11. So the mature erythrocytes would be filled with normal adult hemoglobin because the alpha globin chains could randomly assemble with the healthy beta globin genes. But these red blood cells would also have HBS. They would have a mixture of both normal hemoglobin and the sickle variety. If we go down to the next dash, if the person has both their beta globin genes mutated in this fashion, then they would only make the sickle variety of hemoglobin. That means the maturing erythrocytes would only be filled with the sickled hemoglobin. Now, we can actually detect a person who has sickle cell disease versus the trait. The trait meaning they only carry one mutation. And we can compare them to normal. Yes, we can do simple protein electrophoresis. This is a lot like the serum protein electrophoresis that I told you about in an earlier picture. If you look at the bottom picture, you are seeing a gel. We've loaded blood from a normal person, a person with sickle cell anemia, and a person with sickle cell trait. You'll notice that their HB chains, their beta chains, or their S chains, if that's the case, will migrate in an electrical field differently. So we can compare the people with sickle cell trait or sickle cell disease to a normal person and determine if they have two bad copies of their beta globin gene versus one bad copy. Obviously, individuals with just one bad copy will have some normal hemoglobin. They'll have a milder version of the disease. Some hypoxia, maybe upon exertion or if they're ill, maybe some sickling, but usually not life-threatening. Now, in African Americans, we actually see that there's a particularly high frequency of sickle cell trait. That means one mutation. Whenever geneticists look at a population and they find a higher than expected percentage of them that have this, quote, bad gene, unquote, it makes us say, well, What is it that makes having a bad gene actually serve a good role for these groups of people? There's an evolutionary advantage of malaria that I'm going to discuss in a little bit. I should say an evolutionary advantage with being exposed to malaria that I'm going to talk about. Homozygous individuals only make the defective hemoglobin. This is life-threatening. It leads to crisis, especially when they fall asleep and there's low oxygen, or they have an infection, or they're cold, etc. Now, a lot like the thalassemia, we can introduce hydroxyurea to convert them over to the HbF. Yes, this is going to have higher than normal affinity, but it's better than having the sickling crisis event. How can having the sickle cell trait be an evolutionary advantage? Let me explain. Let's start our discussion on why having the sickle cell trait can actually have a protective effect in the case of malaria. Malaria is Latin for bad air. It was named this because of the false myth that the people were actually getting this infection from breathing bad air, when in fact it was the mosquitoes that were flying around in that air. What happens is the female Anopheles mosquito is one of the vectors for a parasite, the Plasmodium falciparis. People get bitten by a contaminated female Anopheles mosquito that carries the Plasmodium falciparum parasite. The Plasmodium falciparum, one of its vectors is the mosquito. Then it finishes its lifespan in the human host. So the parasite multiplies and goes through several different stages in its life cycle. And one of those stages needs to be in the liver, and then the human red blood cell. Then a mosquito would drink the blood from an infected human and then transmit the plasmodium into another person. This microbe is very clever because it invades our immune system by completing its life cycle segments in our red blood cells. Therefore, our white blood cells don't detect it. They don't detect any foreign antigen. Again, why? The plasmodium hides within our red blood cells. Therefore, our white blood cells, our immune system, would not detect anything foreign. What does erythrocyte sickling have to do with a protective advantage over malaria? Well, it's the parasite's disadvantage, really. In the top right picture, I'm showing you red blood cells that are infected with the plasmodium. What happens is, in sickle cell trait, that means only one bad gene, a person with sickle cell trait gets infected with this Plasmodium falciparum, and the parasite actually consumes some of the oxygen within the red blood cell. It's actually perfect for its own demise. That's because as it's using the oxygen, that's going to cause the red blood cell to sickle. That means if they're sickled and abnormally shaped, poikilocytosis, then they're going to get hung up on the reticular fibers. That means they're going to be destroyed. So the red blood cells that are infected are going to be removed at a higher rate than those that are not because of the plasmodium consuming the oxygen, which in turn causes the sickling. A person is better able to withstand the infection and survive the infection because now the infected cells are being removed from the circulation and the immune system is alerted to the infection. Therefore, if you survive the malaria, you get to propagate. You find a spouse and start to have children. That's the reason why this bad gene for sickle cell is in such high frequency in the African American population. The advantage, like I said, is for sickle cell trait, not for sickle cell disease. Obviously, there is no advantage to having sickle cell disease. I gave you a link down here at the bottom for a PBS website. I think it is still found as a YouTube video as well, so you can learn more about the evolutionary advantage of sickle cell trait and malaria that you can find at pbs.org. The address is shown here. Again, I hope that it is still current. All right, one of our last few slides. Finally, G6PD deficiency. G6PD stands for glucose 6-phosphate dehydrogenase deficiency. This is an enzyme that will take glucose 6-phosphate, and I'll remind you, glucose 6-phosphate is the first step in glycolysis where a phosphate group is attached to glucose to trap it inside the cell. Well, this glucose 6-phosphate dehydrogenase enzyme takes an electron from the glucose 6-phosphate and transfers it to an electron carrier called NADPH. I'll show you a picture of this. All of this electron transfer basically comes down to this. We want to keep iron in the reduced +2 state, right? And you've heard me say that all of us have some methemoglobin in our red blood cells, which means iron in the oxidized state within the hemoglobin. Well, by having G6PD, you can have an electron from glucose 6-phosphate, pass it to an electron carrier, which can then pass it on to an oxidized iron, which will then be reduced to +2. It also can use this electron to quell any free radicals that may have done some damage inside the red blood cell. Well, glucose 6-phosphate dehydrogenase comes from a gene found on the X chromosome. Again, this is going to have excellent genetics, of course, with males being more affected than females. What does this picture of Hannibal Lecter have to do with G6PD? Let's listen and learn. In the movie clip, he says, "A census taker once tried to test me. I ate his liver with a nice Chianti and some fava beans." And then he makes the sound. And the reason why I like this part of the video is because fava beans have a high oxidizing effect. If you eat these types of foods, they are high in oxidants and that can cause more cellular damage. If it's a person who has G6PD deficiency, they're less equipped to handle that oxidative damage. That means they'll get more and more methemoglobin. They actually have to watch what they eat and reduce their intake of fava beans. There seems to be a high proportion of people of Mediterranean descent that have this deficiency. So they need to be mindful of what they eat, and certain types of drugs, like anti-malarial drugs, cause an increase in oxidative damage. Anti-malarial drugs are going to cause oxidative damage to the Plasmodium falciparum and cause its death. But you have to be careful of using these anti-malarial drugs because there's a significant population of African and Mediterranean populations that would be overly sensitive to that drug, such as primaquine. For those of you who have watched MASH or used to watch MASH, there was an episode where the physicians in the unit were treating Klinger because they gave him an anti-malarial drug and he ended up with severe anemia. And it was because he had G6PD deficiency. It took them a while to figure out that's what he had. So they were treating all his signs and symptoms, and they really didn't think he was of Mediterranean descent. Where upon further questioning of him, they realized that he was, and he had this genetic disorder. What does G6PD look like on a molecular level? Well, if you look at these pictures on the right-hand side, first of all, look at the top one. We see glucose entering an anabolic pathway. This is the pentose phosphate pathway or hexose monophosphate pathway. It has many different names. This occurs in the red blood cell. Again, this is an anaerobic way for the red blood cell to make ATP. It can't make ATP through aerobic mechanisms because it lacks mitochondria. We see glucose here turned into glucose 6-phosphate, which traps the glucose inside the red blood cell. The next enzyme is to convert it into another product. Well, in this conversion, the enzyme takes off an electron and passes it to an electron carrier known as NADPH. The NADPH form is the reduced form. This is going to transfer an electron to an oxidized glutathione molecule, and it's going to reduce it. The reduced glutathione is shown up here as 2GSH. That reduced glutathione can then pass on the electron to a free radical, shown here as a hydroxyl group or hydrogen peroxide. The same picture down below that's colored is the same as the one above. What you're basically seeing is a transfer of an electron to ultimately balance out a free radical, or in the case of methemoglobin, to reduce the +3 in iron back down to +2. If a person has G6PD deficiency, obviously they would have higher amounts of methemoglobin and cannot bind oxygen, which would mean the person would have a reduced oxygen carrying capacity. That's the definition of anemia, remember. Additionally, the accumulation of free radicals would cause more cellular damage, and cellular damage to the red blood cell would almost certainly assure it to be removed from circulation at a much higher rate. That concludes our lecture on red blood cell disorders and issues with hematopoiesis. Coming up, we will have lectures on white blood cell disorders and problems with white blood cell synthesis.